Let's go to the first slide.
Next slide, please.
Okay, that's the ECG. With regards to the question, okay, to the ECG recording above, indicate if the following statements are true or false. First is the rhythm on the ECG is atrial fibrillation. Well, the hallmark of atrial fibrillation is actually, firstly, a baseline that does not show any sort of regular rhythm. And the second is the RR interval is irregular. So if you looked at that ECG, the ECG shows a fairly regular rhythm with a baseline that looks like a sawtooth. So this is atrial flutter. Okay. Now,
but you can have atrial flutter and atrial fibrillation ongoing at the same time in some, on some
yes, if you
patients,
do,
right?
you will see the baseline will vary, and you will see the RR interval usually become irregular. You can have atrial flutter with irregular RR, but usually there's a pattern to that, you know. But this is a regular one, right?
Yeah, so this is just atrial flutter.
This is atrial flutter. And this is 4:1 atrial flutter as well. Right. So if you go to the fifth statement, the rhythm on the ECG is atrial flutter with 4:1 AV block, that is true. Okay. How do you tell that? Well, the atrial flutter rate is usually 300 beats per minute. So if it's 4:1, you will expect the rate will be around about 75, right? Beats per minute, and which is close to this one. If you looked at the large squares from R to R, it's about 5 squares. 1, 2, 3, 4, 5. Yeah. So that's about 75. Right? So that's one way of telling it. But you can also look at the baseline and you count the flutter waves. And for every 4 flutter wave, you have 1 QRS that is conducted. So this is 4:1. So you go back to the second statement. If this patient has hypertension and diabetes mellitus, she will be at risk of a thromboembolic stroke. Now, we discussed before that atrial fibrillation, you would look at the CHA2DS2-VASc score. You should do the same with atrial flutter as well. So the assumption is atrial flutter to increase the risk of thromboembolic stroke. Because in most trials, they included atrial flutter and atrial fibrillation together. So if you look at the CHA2DS2-VASc score, any CHA2DS2-VASc score of more than 1 would indicate that there is an increased risk of stroke. In this patient, I mentioned that this is a lady. So she already has 1 risk factor, that is 3. She has 3 risk factors now with hypertension and diabetes mellitus. So that, if you looked at that, the score is 3. She should be on anticoagulation. So that is true. So the third statement is the definitive treatment of cardiac arrhythmia, of this cardiac arrhythmia, is electrical cardioversion to sinus rhythm. The answer is false. It is a treatment of choice to revert the patient to sinus rhythm because antiarrhythmic drugs is particularly, atrial flutter is particularly resistant to conversion by antiarrhythmic drugs. Probably the antiarrhythmic drug that is useful is intravenous ibutylite, which is a class 1C agent, but it is not available in our country. So the definitive way of the first line treatment to get them back to sinus rhythm is electrical cardioversion. And this is synchronous electrical cardioversion, usually at 550 to 100 joules, low joules will be sufficient to get them back to sinus rhythm. But the answer is false because it is not the definitive treatment. So definitive treatment meaning the way to treat this and to prevent it from recurring is actually with radiofrequency ablation. Okay. It is the fourth statement is in association with this, the third. That is, the underlying mechanism of this arrhythmia is macro reentry. And that is true. It is a macro reentry. As compared to, say, atrial fibrillation is not a reentry at all. The trigger is automaticity, and there is a chaotic rhythm in the atrium. So that's not reentry. So if we go to the next slide. So this picture here describes how the atrial flutter circuit lies within the right atrium. Okay, so this is typical atrial flutter. The commonest atrial flutter is called typical atrial flutter, and the other term for typical atrial flutter is a cavo-tricuspid dependent atrial flutter. It simply means that the circuit involves an electrical circuit around the tricuspid valve. Right? So if you look at typical atrial flutter, it is an anti-clockwise rotation. This is a view from below, from the right ventricle. So from the right ventricle, you see that the macro reentry grows around anti-clockwise around the tricuspid valve. So it passes between the lateral wall, and then it goes down in front of the IVC, and then it goes between the tricuspid valve and the coronary sinus. So that that isthmus between the coronary sinus and the tricuspid valve is called the cavo-tricuspid isthmus. So that's why this is called a cavo-tricuspid dependent atrial flutter. The reverse typical atrial flutter is actually in a clockwise direction. So the way to differentiate this, if you looked at lead 1, lead 2, lead 3, and V1. If you notice, the typical atrial flutter, which is anti-clockwise, have positive P waves in the V1 lead and negative, generally negative leads in 2 and 3. While the reverse typical flutter, which is the clockwise one, it has a negative P wave in V1. Imagine the flutter waves coming up from below towards V1. Therefore, it gives a positive V1 lead in, the P waves in V1 will be positive. And if you look at a clockwise one, it's actually moving away from V1 because it is clockwise, it's going downwards. Therefore, the V1 lead will show a negative P wave actually.
Nizar, we have a question from Dr. Kaur. He asked if it's correct to say in AF that is chronic, no cardioversion, just anticoagulation. Yes. Again, the anticoagulation is...
You can actually, you can actually cardiovert them. If your intention is to see if they can maintain sinus rhythm. But either you cardiovert or you do not cardiovert them, they still require anticoagulation because their risk is dependent on their CHA2DS2-VASc score, right? So if their CHA2DS2-VASc score is more than 1, you should consider anticoagulating them, despite the fact that you are actually cardioverting them.
Okay, so actually, Dr. Kaur, if the patient has already atrial fibrillation and is more than 48 hours, you need to anticoagulate the patient if the score is high, and then wait about 4 to 6 weeks, hoping that the clots have all been dissolved, and then you can attempt to cardiovert the patient. And then after cardioverting, you still need to continue the anticoagulation.
Right. There is a caveat to that. Even if their CHA2DS2-VASc score is less than 1, that is, let's say, is 0, but your long-term aim is to cardiovert them, say, after 3 weeks, right? You still need to anticoagulate before you cardiovert. Yeah.
Only if they come before 48 hours, then you do not need to cardiovert them. Next slide, please.
Okay, this is the second question, right? Now,
all your patients are ladies, huh?
because SVT is common in women, right? Yeah. The young lady who presented to the ER with ECG2 complains only of palpitation. Her vital signs are fine. State which of the following statements are true and false. Okay. IV verapamil infusion at 1 milligram per minute until termination, or a maximum of 20 milligram is reached, is an option of management for the arrhythmia. Answer is true, right? That probably is the preferred way of giving IV verapamil rather than slow injection bolus, because there is an increased risk that you might cause the blood pressure to fall, or you might get persistent AV block actually, right? So once, let's say you're giving this method, 1 milligram per minute, and the SVT terminates, then you stop the IV verapamil infusion. Do not continue. You stop. Right? So that is true. The second
I
statement
think it's
says,
also it's also a matter of preference. I think I've worked with Nizar for some time, and he loves to give infusion. Even his sedation goes. he gives he gives his sedation in infusion. Whereas I'm more, because you have to wait for the nurse to bring the infusion pump. I am less patient, so I'll just give a slow bolus most times. Yeah.
so if you're less patient, IV adenosine is the treatment actually. But
Yes, that's
in
right.
this second statement, IV adenosine 6 milligram given slowly, the first line treatment, is false. Because if you give 6 milligrams slowly, it's metabolized so quickly, it will not have any effect. You need to give 6 milligram in a bolus, a quick
Fast
bolus,
bolus.
followed by a 20 mils flush. That is certainly, if you look at statement 5, that is true. So statement 2
But
is false.
the 6
Statement 5,
milligram is true. Yeah.
yes, 6 milligram is true, but the way that you give it must be fast, right? Now, third statement, IV atropine 1 milligram should be an optional treatment, is false. Atropine is never used for tachycardia. It's actually used for bradycardias. So that is definitely false. Number 4, modified Valsalva maneuver is the first line treatment. That is true. You should attempt a Valsalva maneuver before you actually try drugs, because that's safer as well. Any questions has cropped up with this?
So far, none. Only Dr. Kaur has asked us a question.
Okay.
Okay. We finish this one, maybe more questions will come. Please do not hesitate to ask us any question.
Right. If you
Okay.
compare this ECG to the last one, this one tells you this is a broad complex tachycardia. Okay. So any broad complex tachycardia, you must assume that this is VT until proven otherwise. But
Yes.
there are other features in this ECG that suggest that it is VT. If you look at the baseline, particularly in long lead 2, the baseline, there is some imperfections. They're not exactly the same. So that usually tells me that there is some VA dissociation, right? Which means the atrium and the ventricle is beating at different rates. The other feature that obviously makes this ventricular tachycardia is if you look at AVR, you see a prominent R wave there. And that usually would be very specific for ventricular tachycardia. So let's look at the questions now, the statements. Next question. Now you are called to the ward, and a 60-year-old with the above ECG is complaining of chest pain. He is sweating profusely, and his mean arterial pressure is 58. Which of the following are true and false? Number 1, you must inform your medical officer that you have an unstable patient with a ventricular tachycardia. I think everybody should get this correct, and it's true. You should inform somebody that you have an unstable patient, right, as a housemate. Number 2, the patient should be propped up and be given oxygen. Now, if you have a patient whose mean arterial pressure is low, if you prop up the patient, even if you give them oxygen, that might be actually detrimental to them. So that is false. The correct thing to do would be,
And you
place
can't
them, yeah,
you can't cardiovert them if the patient is propped up. So if the patient suddenly turn into VTF, also there is a problem.
yeah. So you should put the patient in a Trendelenburg position so that they get better perfused. Cerebral perfusion is better, right? And the third statement is true. Number 4, the arrhythmia must be synchronously cardioverted to sinus rhythm as soon as possible. I'm sure everybody got this right. It's true. And number 5, you should prepare to have the crash cart nearby and be prepared to defibrillate the patient if it's necessary. That is true. Any patients with ventricular tachycardia can deteriorate at any time, especially when they are unstable to VF. So you should be on standby to institute defibrillation if the patient develops such, while you're waiting for somebody senior or somebody to give sedation for this patient. Okay.
Let me stop you here because I want to say hi to Zubaida. Zubaida just joined us. Zubaida can still join the quiz while we are talking, but you might get the question all right. Okay. And then Dr. Kaur asked.
Hey, no, sorry, I off the quiz already.
Oh, you're off the quiz already. So Zubaida, you just have to listen to us now. If cardioversion cannot be sustained, when would you give up? Sorry, Dr. Kaur asked. Okay, it is not difficult to cardiovert a patient with atrial flutter or atrial fibrillation, and usually they will cardiovert quite easily. The problem is they can go into atrial fibrillation again quite easily in most patients. So how many times would you attempt? I don't even, if let's say a patient has had atrial fibrillation and then has gone into persistent atrial fibrillation, I usually won't attempt to even cardiovert because I know that they will always come back with atrial fibrillation. Maybe Nizar would like to answer that.
I usually give every patient a chance, especially if that is the first presentation in atrial fibrillation, right? And if, let's say, for example, you take two sort of scenarios. The first would be it's less than 48 hours. The patient, you want to try and get the patient to sinus rhythm. Usually these patients can be easily reverted to sinus, right? So you can cardiovert them. And if you cardiovert them, let's say at 100 joules, and then you try 200 joules, and they persist in AF, right? I would then probably stop and probably try, let's say, institute antiarrhythmic drugs. And if the patient is now beyond 48 hours, I would delay their cardioversion for 3 weeks before I call them back to have a second attempt. Right. Now, if let's say the patient is more than 48 hours after the onset of arrhythmia, the second scenario. So I won't cardiovert immediately. I will probably anticoagulate for 3 weeks, and then probably bring back some of this patient on a weekly basis to see whether they revert. Sometimes they revert on their own while waiting, you know. But otherwise, you can institute antiarrhythmic drugs a couple of days before you want to cardiovert the patient. So my choice usually is flecainide if the patient does not have any other contraindications. Flecainide 100 milligrams BD, say 3 or 4 days before. And then if they're still in AF on the day, I cardiovert them, and usually they will be easier to cardiovert in that situation. Sometimes even the flecainide will cardiovert them while they are waiting for the electrical cardioversion. So does that answer your question?
Next slide, please.
Right. this is so a different sort of flavor. Now you know that there are more P waves than QRS complex, right? Okay.
Yes.
So let's look at the question. Which of the following statements relating to the rhythm strip above are true and false? The rhythm shown is an atrial tachycardia with AV block. So that is false. Now, if you were to look at the rhythm itself and count the rate of the P waves, the P wave is only 75 beats per minute. So it's certainly that's not atrial tachycardia. And the QRS is also not a tachycardia. So that is false, right? Sometimes you can be tricked. Okay. Number 2, the tracing shows a Mobitz type 2 AV block. Let's show them the next ECG. Yeah. So here you notice the upper strip shows you a Mobitz type 1 AV block. What you see is a P wave with each QRS complex, but on the fourth, the fifth P wave is not followed by QRS complex. Leading to that drop QRS complex, you see the PR interval gradually prolong. So this is Mobitz type 1 AV. While the panel below, you notice that the PR interval before the QRS is constant, but you get drop QRS complexes after several beats. So the second beat is dropped, the fifth beat is also dropped, the sixth beat is dropped. So this is Mobitz type 2 AV block. So if you go back to the ECG in question now, how do you tell whether this is Mobitz 1 or Mobitz 2? Because in this situation, it is actually 2-to-1 AV block. So 2-to-1 AV block is actually a category by itself. It doesn't fit Mobitz type 1 or Mobitz type 2 because it can be either one of them, but you need to do certain maneuvers. You must do certain maneuvers. So this is actually, if you look at the statement, the rhythm in the tracing is a 2-to-1 AV block. That is true.
True.
The second statement is false. Third statement is true, right?
So second statement is not false one. It's just
you can't say that it's Mobitz type 2.
This is a trick question.
Because you can't see the gradual prolongation of the PR, right? When it's 2-to-1. There is no gradual prolongation. So 2-to-1 is a separate category, which you'll need to determine whether it's Mobitz type 1 or Mobitz type 2. Okay.
I see.
Yeah.
Okay.
So the treatment of Mobitz type 1 AV block requires a permanent pacemaker implantation. The answer is false. The majority of people with Mobitz type 1 AV block, the block is usually in the AV node, and the majority of them have an intrinsic anomaly. Sometimes you get high, vagal tones. Very fit young people may get Mobitz type 1 AV block. Whereas Mobitz type 2 AV block is usually his or infrahisian. That's why Mobitz type 2 requires a permanent pacemaker. Mobitz type 1 does not, actually. So that answer is false. That's why with Mobitz type 2-to-1 AV block, you need to determine where is the block. Is it in the AV node, which is rather benign, or is it his or infrahis, which is more malignant? They will lead to AV blocks later. So the fifth statement, making the patient with the above tracing exercise may help differentiate Mobitz type 1 and 2 AV block. Yes, you can. That is true. So imagine you put the patient in 2-to-1 AV block on a treadmill, and what you will see is the sinus rate will accelerate. You will get more P waves now. And you will now want to see what the association of P waves with the QRS. If there is gradual prolongation, that's Mobitz type 1. If there is no gradual prolongation, there is increase in number of AV blocks, then that's Mobitz type 2. So that's one way of actually telling the difference. Let's look at the next slide after the tracing, after this, okay. So these are other ways of actually determining where the block is, right? Now, if the QRS is wide, there is bundle branch block. But with bundle branch block, you can't tell whether there is infrahisian or actually AV node, so it doesn't help. But if you have a normal QRS in AV, the block is usually in AV node or the His bundle. It can be both. So QRS width doesn't help you very much. Now, the PR of the conducted P wave. The PR interval is long, more than 30.3 seconds, right? 0.3 seconds. The odd thing is the block is usually in the AV node. Most block infrahisian or at the level of the His, the PR interval is short, is less than 0.16 seconds. Besides exercise, you can give atropine. So what does atropine do? It actually enhances this sympathetic tone. So if there is an improving conduction, that's the AV node. If it worsens the conduction because conduction reaching the His bundle increases, it goes into refractoriness, therefore the block increases, that is actually infrahisian, right? You can also do carotid sinus massage, you know. So if the conduction block worsens, that's the AV node because you're actually stimulating the vagal.
So you want to worsen the AV block while your patient is already having a slow heart rate.
2 to 1 block, yeah. So you need to do this carefully, yes. But you can tell the difference.
I think as a house officer, please don't do it on a patient with AV block.
That is why exercise is the best way to do it, right?
Yeah.
The patient is stable. Finally, retrograde conduction. It probably, if there is present, the block is usually at the His or infra-His. But if it's absent, then the block can be anywhere. Right? So those are the things that you might want to store to help you subsequently. Okay, next
slide, please.
Questions. Yeah. So this is the 2 next ECG shows, one is this tachycardia, and this is post reversion, right? So let's look at the questions now. All right.
Tan, have you tabulated all the answers?
Which statement relating to the 2 ECGs above are true and false? The arrhythmia is an AV re-entry tachycardia and is due to a Wolff-Parkinson-White syndrome. Answer is true. Right? So let's go back to what Wolff-Parkinson-White is. The difference is when they're in tachycardia, you don't see the delta wave because the conduction now is through the normal conduction system, retrogradely goes up the accessory pathway, and therefore the QRS complex becomes narrow. Right? Usually because in sinus rhythm, you will see the delta wave because the conduction travels down both the normal conduction as well as the accessory pathway. Can we go to the figure, the next one? After the question, yeah, that will help. Yeah, okay. So if you look at in sinus rhythm, the diagram on your far left, in sinus rhythm, conduction travels to both the accessory pathway, which is on the right ventricle in this situation, as well as through the AV node, right? So there will be a portion of the ventricle that is excited through the accessory pathway. So that is why it's called pre-excitation. So the slurred upstroke is due to that area that is pre-excited. Now, during tachycardia, which is usually autodromic or AV re-entry tachycardia, conduction goes down the AV node, down the His bundle, to the right bundle, and then
this is the middle one, right? The middle
That's right, this is the middle one. Retrogradely through the accessory pathway and then form a circuit. So then you will see the P waves usually after the QRS complex because they are in sequence, right? They're not in parallel, they are in sequence. So you'll see a P wave, it comes after the QRS complex. That tells us that this is an AV reentry or AV reentry tachycardia. Now, there is another rare condition, seldom seen spontaneously, probably less than 5% of cases, an antidromic tachycardia, where it actually goes down the accessory pathway and then up the normal conduction, go down the right bundle, up the his bundle, retrogradely through the AV node, and then goes the other way. So that is called an antidromic tachycardia. But the common antidromic tachycardia occurs, let's say, during atrial fibrillation. So when you have atrial fibrillation, conduction down the accessory pathway is all or none. And if you have atrial fibrillation, like say 600 beats per minute, the ventricular rate can reach up to that rate, and that can be potentially lethal. If you go to the last ECG, so this is an example of a pre-excited atrial fibrillation. So how can you tell? If you look closely in certain leads, particularly, let's say, in V4, you will see delta waves in the upstroke of the AV node, the QRS complexes. The other hallmark is these patients can usually be quite stable. They'll be talking to you. They complain of palpitation. And you look at the RR interval, it's irregular. But this is not VF. It looks like VF, but it's not VF. It may confuse you with polymorphic VT as well. The thing to do,
this is
not
actually AF?
excited AF, yes. The thing not to
Oh,
do in this situation is actually not to give any drugs that block the AV node. Because if you do that, the AV node is blocked, all conduction goes down the accessory pathway, and that is a sure way of actually inducing VF. So if you're uncertain, this should be a semi-emergency, should call your seniors, should consider actually cardioverting the patient. That would be the safest bet. Okay. Alternatively, you can give drugs that block the accessory pathways. And this might be IV immunoderone or a class 1C agent like flecainide. But
Nizar, I have a question.
Sure.
Sorry. So if you have this Wolff-Parkinson,
Yeah.
and the patient can have, let's say, AF, not at this rate, but
Right.
AF going through the AV node.
Right.
Okay,
It
and then
doesn't
somebody,
conduct down the accessory pathway.
yes, okay.
Right.
So
Okay,
nobody noticed that, because, okay, let's say this patient has chronic AF
right.
or persistent AF, came to a doctor, and the doctor saw it's AF, okay,
Okay.
and then tried to control the rate by
Right.
using something to block the AV node.
Generally, that should be safe because the AF is slow, and yet it is not conducting through the accessory pathway. You're relatively safe, but you still probably do not want. I mean, if the rate is slow, why would you want to give an AV node blocking agent, right?
No, I mean the rate is, let's say, 120, 130. So you do not suspect Wolff-Parkinson. So you
Right.
give something, and
To
then
slow
you
down the heart rate, and then
to
you
slow down the
notice
heart.
that, yeah, you notice that there is delta waves. In all possibility, the rate, the ventricular rate is not going to be rapid, right? There are still some risks involved because in that situation, the patient might be at rest and he's comfortable. But if you were to exercise them, you enhance the conduction through the accessory pathway. You don't know what the heart rate, the ventricular rate would be. So there is still some small risk involved in that situation. There are two things that might be safe. When the patient is in sinus rhythm and you only see intermittent delta waves, which means there is only intermittent pre-excitation. That means that, generally speaking, this rhythm, this accessory pathway is benign because it doesn't conduct very fast. The second way is actually when the patient you put the patient on a treadmill during exercise, and you see the delta wave disappear at a rate of 120. That generally would be safe because when the patient exercises further, it's already enhanced by adrenaline and sympathetic drive, yet the accessory pathway cannot conduct, then generally you would say that is safe. Right? But otherwise, you cannot tell. There's no way of telling whether the accessory pathway can conduct rapidly or not. Okay,
So it is better not to risk it.
that's right. Let's go back to the statements. Okay, so the patient has a potential risk of sudden cardiac death. Yes, she has, right?
True.
Because that's true.
Yes.
This young woman who presented with the above ECG should be treated with oral amiodarone for the long term.
False.
The answer is false because it's a young woman. She's going to be probably a childbearing. I mean, she's in a childbearing age, and amiodarone is a very toxic drug. You have problems with the thyroid in about 30% of patients. You can develop pigmentations of the skin, and it's unsightly. You might actually have photosensitivity, and the worst sort of side effect would be pulmonary fibrosis. So you don't want to submit a young woman to long-term amiodarone. So the next statement says the definitive treatment for patient is catheter ablation. Is therefore true because it is highly curative. Probably in 98% you can cure them, and you might only need one procedure in the majority. Less than 5% as a recurrence. Number 5, IV adenosine is to use to terminate the arrhythmia is safe to be used in pregnancy. That is true because firstly, adenosine is a natural occurring substance. It is rapidly metabolized by the RBCs, and the half-life is only 6 seconds to 8 seconds, so it doesn't have any long-term problems. Okay, any questions for that?
No questions.
All right.
So far, everybody seems to understand everything.
Good.
Next
So
quiz.
we're at the end of the question session.
Okay, we are almost finishing soon. So we have done this. Go on.
We finished.
Oh, we finished.
We
Oh,
finished.
we are on time. We've just
Yeah.
finished at 6.
Right.
I hope and you guys can answer some questions, and then we will
We open it to
answer
Q&A,
them.
right?
Yes, we're open to Q&A, and then we would also hope that you can give us suggestions to what we can do in the next coming week. In mid-October, I'm going to arrange another webinar with the orthopedic surgeon. He's a pediatric orthopedic surgeon. We will talk about common fractures, common pediatric problems with orthopedic, and how to manage trauma with an open fracture. And then we will also then fluid management and maybe case presentation. Any questions at all? So far only Dr. Cole. Maybe they need to digest all this. And I really need to work on my
Your camera.
okay. Yes, somebody said it was great. Thank you. Oh, thank you. I think the quiz was very interesting. Don't you agree?
Yeah.
I would like to thank Tan for coming up with this quiz. Next time we will have more quizzes. And then please join us in Telegram. We have this forum, and I would like it if we would love it if some of you can actually ask some questions. Nizar and I are there to reply them. It may not necessarily be cardiology, but we will, if we can't answer it, we will get back to you. Yeah, because we get to learn too. Anything else, Nizar?
No, everything's good.
Everything's good, huh? So no questions. Okay, see you guys next time. Bye.